Well, I show 11 o'clock, so let's get started. Hi, everyone. My name is Richard Howard. I'm the Associate Executive Director of the Spondylitis Association of America. Also online from the SAA is Aline, and she's the Editor-in-Chief of Spondylitis Plus, and she'll be fielding any questions today. I want to welcome you all to SAA's first webinar in this series. We've done a series in the past, but this is a new series. There are people attending from all around the country and the world, theoretically, so we're excited to see that we can reach more people through this technology. In just a few minutes, Dr. Pamela Weiss will provide a presentation on juvenile spondyloarthritis, and this webinar is for parents and their other concerned adults. Before we get started, let's go over a few housekeeping items. First, due to the number of people attending today's webinar, everyone's line has been automatically muted to avoid noise distractions. You're welcome to ask questions and comment in the questions section. In fact, you're encouraged to do that. Aline will ask these questions for everyone to hear during the question and answer portion. We are recording this webinar and it will be made available on our website and through YouTube early next week, as early as Monday. Our agenda today is straightforward. We have a brief introduction on the ongoing programs available at the Spondylitis Association of America, and I'll be doing that. And then Dr. Weiss will offer a slide presentation of the topic, and then there'll be a question and answer period. The doctor will occasionally ask a question during the webinar, and then you'll be able to see the results right away. To show you what it's like, we're going to do a poll right now. We're going to do a simple poll to see how people are connected. So, Aline, maybe you want to launch that poll? Okay, so on your screen or smartphones, there should be a poll launched, and then you click on that, how you're connected today. Looks like there's 71, 84% have voted, 90% voted, 94% voted. So we'll give it another second or two and we'll close the poll. Okay, let's close that poll. And let's take a look to see how it looks. So it looks like most people are viewing the webinar from a desktop, but 17% on their smartphones. All right, so that's how the polls work, and she'll have some questions during this webinar. I did want to take one more poll to see who's joining us, like why they're joining us. So my second poll. Let's start that one. All right, so why are you joining us today? Do you have or care for at least one child with juvenile SpA? Do you have juvenile spondylitis? Because there could be people who are younger on the webinar. And do you suspect you have someone a child of yours has juvenile SpA? So we have 91% voted. Someone took away their vote. Someone rechanged their vote. Okay, we're at 91%. So let's close that poll too. And so 58%, most people on this call today have a child with juvenile spondylitis. Some people on the call with juvenile spondylitis. Okay, and there's some people suspecting. There's 29% of others. And others could be a lot of things. It could be other rheumatologists, other people in the field. So let's move on. Well, thank you for participating, and it helps make it more interactive and gives us some feedback about who's on the call. When you exit the webinar today, there'll be a very brief evaluation will come up. Since this is our first webinar in years, your feedback is especially important to us. We want to know if the webinar has met your need, and we also want to know what other webinar topics you'd like to see. So please complete the survey. It takes less than 3 minutes. It took me not even 2 minutes to do. If you need assistance in the webinar, use that question box on your control panel. If that's not available for you for any reason, email us at info@spondylitis.org, and we're monitoring that email address today. All right, so Dr. Weiss will begin the juvenile spondylitis topic in a couple of minutes, right after I quickly give you an overview of some of the spondylitis resources that are available to you. So the Spondylitis Association was established in 1984, which is just over 30 years ago. And our mission is to lead the quest for a cure and support people with spondylitis. SA is at the forefront of this effort. I have another poll to start now too. And this is my last poll, I promise. Aline, do you want to launch that one? So this poll is, what SA resources have you utilized? Have you come to a live seminar? Our next one's in San Francisco. Our last one was in Anaheim. We were in New Jersey. We've been in San Diego. Have you used our brochures, follow-up materials? I know it's a longer poll, so it takes a little bit longer to vote, so bear with other people on the call. We're at 56% voting, 64%, 69, 74%. I want to get up in the 90s before we close the poll. 85, 87, 90%. Seems like so far most have seen SA brochures, and over half are getting a news magazine, Spondylitis Plus. Let's close up poll at 95%. Here's the results for everybody to see. So as I mentioned, many people have seen our brochures. 38% have been on our Facebook or Twitter or social media, and 41% have used our forums. Okay. So spondylitis. So what do? We do three main things. Like to categorize it in three main things. One is we serve the diagnosed. We have things like Spondylitis Plus, our monthly email, our stopas.org website, live seminars. We have an 800 line that we field Monday through Friday. And finding the treatment for the right patient is essential. And using the most current scientific knowledge of the disease is important. So what we did this year is SA, along with the American College of Rheumatology and Spartan, established treatment guidelines. And these guidelines will be made public by ACR in June. And we already have plans to update them every 2 years so they are stayed current. Let me share one more way we serve. We had a tragic call with a person with AS who hurt himself working around his house. He was found unconscious, and when the EMT arrived, they used a backboard to transport, and he literally and fatally broke his neck during that transport. So SA developed a training DVD for EMTs so that would never happen again. Today you can call the office and get a copy of this DVD and take it to your local neighborhood fire department. So those are some of the things that SA does to serve the diagnosed. We also serve the underdiagnosed and the undiagnosed. So these are people who haven't had a diagnosis yet, maybe haven't seen a rheumatologist yet. And as you know, some people go years and years without knowing what's wrong with them and what can be done to help. We launch awareness campaigns for patients. We also launch awareness campaigns for medical professionals, including radiologists, chiropractors, dentists, primary care physicians, and rheumatologists. People have told me that they're essentially self-diagnose themselves from the information we provided here. And they take that information to a doctor, and they finally get diagnosed, and they get on a management plan. All right. The final thing I wanted to mention on the slide is that we support research. As you know, some diseases are incredibly difficult to cure. SA encourages brilliant doctors and researchers to spend their careers on spondylitis. We've launched long-term research to understand disease impact over the life of a person. We also see promising news research. We like to bring the best and brightest minds in multiple disciplines together, and we do that at our Unmet Needs Conference at the NIH. Okay, and then you see these flipping around. We're always highly rated as far as independent charity navigators. So these are some of our highlights. Spondylitis Plus I already mentioned, our hotline I already mentioned, our website I already mentioned, brochures most of you are already familiar with. We do have on this one, you'll see teenspondylitis.org. That's what we call our SWIFT site, and that's a site made for teens. Of course, you're familiar with webinars. We have forums. And then most people today, I think, connect with us through social media, although our website gets a tremendous amount of visitors every day. But as far as people wanting to stay on top of things, they usually do that through the Facebook, LinkedIn. All right, and then really, there's no substitute for face-to-face interaction with other people living with the disease and sharing experiences. We have 38 in-person support groups across the country. We have one tomorrow in Los Angeles. We have a rheumatologist researcher coming out talking about fibromyalgia and spondyloarthritis. Okay, so in some SA works, we participate in funding research, recruiting people to participate in research, and we were the first to conduct patient-centered research in spondylitis. We provide continuing education for physicians and medical professionals, and we work to raise awareness in the United States and worldwide, really. And as I might have already mentioned, we're not supported by any government funding. We're a membership organization, and we've been doing it since 1984. All right, with all that said, I'm done. We can move right along to the main feature, which is Dr. Pamela Weiss. Allow me, hang on one second. Pamela Weiss, MD, MSCE, is a pediatric rheumatologist at Children's Hospital of Philadelphia, whose clinical and research interests are focused on juvenile spondylitis. She is board certified in pediatric rheumatology and pediatrics. Dr. Weiss is a co-principal investigator of the American College of Rheumatology, that's ACR, in a JIA treatment recommendations update, as well as a member of the core expert panel for development of the 2014 clinical practice guidelines for axial spondyloarthritis. That's the collaborative undertaking between ACR, SAA, and Spartan. Dr. Weiss is also a recent participant of the SAA's Young Investigator Award, which is one way we encourage people to stay in the field of spondyloarthritis in recognition of her outstanding contributions to the care and understanding of patients with spondyloarthritis. Okay, and with that, Dr. Weiss is taking over.
I just want to make sure you can see my screen. Is that correct?
Correct.
Okay. Good afternoon or good morning, depending on if you're East Coast or West Coast. In the next 25-30 minutes, we're going to go over a lot, but I'm trying to hit topics really that I've heard from parents and families of people that I've seen in clinic to try and hit the most high topic area, interest topics for you guys. So the first thing we're going to talk about is juvenile spondyloarthritis. What exactly is it and how is it defined? Classification is confusing not only for parents, but also for many of the pediatric rheumatologists out there. We're going to touch briefly on the role of genes in the environment in regards to the pathogenesis of disease. We're going to talk about the unique features of spondyloarthritis and things really that differentiate this from other kinds of juvenile arthritis. And we're going to focus in particular on enthesitis, which is tenderness where the ligaments and tendons attached to the bone, as well as arthritis of the lower back, which is called sacroiliitis. And then we'll finish up talking a little bit about treatment options depending on what the manifestations of disease the children have.
Did you want that first poll?
Oh, sure, yes.
Okay.
Thank you.
Yeah, sure. So the first poll, with the getting started, is how comfortable are you with your understanding of juvenile spondyloarthritis? Do you have a very good understanding, know the basics, want a better understanding, or are you new to all of this? We have 37% voting. About the majority right now are going towards I know the basics, but I want a better understanding. 86% voting, just a couple more, and we'll close the poll. 88. Okay, I'll close that. There we go, 90%. Let's close that poll so you can see the results. So half know the basics, but want better understanding.
Okay, terrific. Okay, so chronic arthritis is actually the most common rheumatic condition of childhood. And juvenile spondyloarthritis accounts for 15 to 20% of all juvenile arthritis that we see. It's also really important because 10% of adults with ankylosing spondylitis had symptom onset while they were children or teenagers. So the next question is, what exactly is it? There's lots of different answers for this, but I think the best one is that juvenile spondyloarthritis is a group of diseases that are similar in that they're characterized by varying degrees of any of the following that are listed here. So chronic arthritis, which is most often lower extremity, enthesitis, which again we'll talk about in a few minutes in more detail, sausage digits, which are also called dactylitis, inflammatory bowel disease, acute eye inflammation, sometimes called acute anterior uveitis or iritis, as well as psoriasis. Okay, so classification of juvenile spondyloarthritis, again, is really confusing for lots of people. The most important concept for you to know is that it's an umbrella term. Within this umbrella, there are multiple diseases, again, all of which are a little bit different. If you go to see a pediatric rheumatologist, they may not use this classification umbrella term. They may use something called enthesitis-related arthritis, which is one of 7 categories of chronic arthritis. So I just want to let you know why you might be hearing different terms. So under the classification criteria that most pediatric rheumatologists use in the office, there are 3 categories that fall under this umbrella term. Enthesitis-related arthritis is going to account for the majority of these children, but children with psoriatic arthritis and undifferentiated arthritis also fall under this umbrella term. There's also several conditions that do not fall in the classic scheme of juvenile arthritis that the pediatric rheumatologist will use that are considered under juvenile spondyloarthropathy, and those are IBD-associated arthritis, juvenile ankylosing spondylitis, and reactive arthritis. And so the classification scheme that most pediatric rheumatologists use is listed here. This is according to the International League of Associations for Rheumatology, and in that classification, there's 7 kinds of arthritis that children can have. And again, the bottom 3 are the ones that we consider as part of juvenile spondyloarthritis. So there's a strong heritable influence in ankylosing spondylitis, which is an advanced form of juvenile spondyloarthritis, and about 20% of children have an affected family member. So we know that HLA-B27 is the most important genetic factor. 80 to 90% of adults with ankylosing spondylitis are B27 positive, and in contrast, it's only about half of children with juvenile spondyloarthritis who are going to be positive. To put this in perspective, about 6% of the general U.S. population is HLA-B27 positive, and the reason that's important is because if you're B27 positive, or if you have a child who's B27 positive, it does not equal disease, and it does not mean they're going to get disease. So for people who are HLA-B27 positive, who have no family history of anybody with HLA-B27 associated disease like spondylitis or ankylosing spondylitis, their risk of getting disease is between 1 and 3%, so pretty low. If a child is B27 positive and has a positive family history of ankylosing spondylitis or one of the other B27 diseases, that risk increases about tenfold, but we're still only talking about 20% risk. For children of parents with spondylitis, and I suspect that that's a good portion of you today since not all of you have a child with spondylitis, the risk for male children is higher than that for females, but the risk for male children in general is about 5 to 10%, 20% if they're B27 positive, but close to 0 if they're B27 negative. So one question that got sent in advance that I thought we could address quickly is, for those of you out there who are HLA-B27 positive and have ankylosing spondylitis or one of these other B27 associated conditions, should you have your children tested? And so I get this question not uncommonly, and I would say if you have a healthy child who has absolutely no symptoms whatsoever of spondylitis, I wouldn't advise getting them tested. And the reason for that is, based on the stats that I just showed you on the last slide, even if they are B27 positive, the odds are still in their favor that they're not going to develop disease. And in that case, I think the old saying, the worst thing that ever happened to me never happened, is sort of apropos, and that finding out that a child of yours is B27 positive is going to cause an awful lot of anxiety that may all be for nothing.
Did you want to ask, you had 2 poll questions set up in advance. One was,
Sure,
how many of you have children who are HLA positive? Do you want to ask that one?
Sure.
Okay. So if you could, if everyone can vote on this, we have 40% voting. You're voting much faster these days. 67%, 71%, 78%. If we can get into the 90s, I'll close the poll. So just a few more seconds. Okay, we have 84%. So let me close that poll and share it so you can see the results. Okay. And then you had one more question along these lines, is how many of you worry about your child having this condition? Oh, I'm sorry. How many of you worry that your children or grandchildren will inherit this condition? I'm very worried. I'm somewhat worried. I'm not worried, or it doesn't apply. And we have 71% voting, 84% voting. A couple more. Very good. I'll close it. And it looks like over half are somewhat worried, and 33% are very worried. I'll close that poll.
The purpose of this slide is not to hurt your eyes, but the purpose really is just to show you that there are a lot of genes besides HLA-B27 that we think have an influence on the pathogenesis of this disease. But HLA-B27 far and away accounts for the most amount of heritability. And that's only about 23%. But if you look at this laundry list of genes that have been studied, each of them contributes less than 1% in terms of the heritability. So there are a lot out there. None of these genes are routinely being tested as part of clinical practice, but it's just interesting to show you that, we're learning a lot, and the learning curve is steep. I have an arrow pointing to ERAP1 because that's one gene that has been in the medical literature very recently, but it's only really applicable to those patients who are HLA-B27 positive. Those genes with stars to the left of them are all genes that are found to play an influence in patients who are B27 negative. So another thing when we talk about genes in the environment that's really important is to talk about the gut and inflammatory bowel. So there's a well-known association between ankylosing spondylitis and bowel inflammation. So 70% of patients with ankylosing spondylitis have some sort of inflammatory gut involvement. And up to 6% of patients actually have coexisting bowel disease. And we see this not uncommonly in the kids at all. Patients with ankylosing spondylitis, as well as children with enthesitis-related arthritis in some preliminary studies, have been found to have altered microbiota, or the bacteria that live in your intestines, in compared to healthy controls. So it's thought that altered bacteria may contribute to risk of disease and maybe even the phenotype of the disease. But it's not only just that patients may have different bacteria living in their gut, but it's also that they may have a pathologic response to normal bacteria that are living in the gut. And so this is an area of a lot of active research, and I'm looking forward to hearing more about this because I think it's going to shed some light. I think we have another poll question for this, right, Rich? Yeah. So this question is, how familiar are you with the term enthesitis? Okay, so it looks like about 2/3 of you are familiar with enthesitis, and the other third, it's good. So we can talk about this, and hopefully for those of you who are familiar, I'll teach you something new. Okay, so enthesitis is what we call inflammation at the insertion of tendons and ligaments into the bone. This is different than arthritis. On the right is a picture of somebody's heel, and the area that is bright white is where the Achilles tendon attaches into the back of the heel. So in a normal person who doesn't have inflammation there, that intense white signal shouldn't be there. The other thing that you can see with the little arrows is that the edge of that bone is really jagged. And so that's what can happen when enthesitis is long-standing and isn't treated. And the inflammation can start to eat away at the bone and cause what are called enthesitis, or similar to what you get with long-standing arthritis, which is called erosions. And so enthesitis tends to affect the older boys. It tends to come and go. Sometimes it stays and is really problematic. We think that it affects the lower extremities more than the upper extremities. In contrast to pain that children have with arthritis, which tends to make them feel like 90-year-olds when they get up in the morning and they're stiff until around lunchtime, these kids actually feel fine when they get up in the morning, but it's after they've been out playing sports, running, basketball, everything that teenagers do, they feel awful when they're done. And that's because they've been moving, stretching their tendons and ligaments with all their activity. Things get inflamed, and then they feel worse. Some of these kids may have morning stiffness and gelling, just like the kids with arthritis, but it tends to not be as prominent. And sometimes enthesitis presents alone in the absence of arthritis, and this can be an early sign of juvenile spondyloarthritis. So here I'm just showing you a picture of the bottom of the foot. So on the left is sort of what you would see if you lifted the skin off. And on the right, where the dots are, really where the physician's going to examine the bottom of the foot to feel for soreness. And so those are what we call the entheses. And those are the areas that tend to be affected the most. So this would be the plantar fascia. This is the area that gets sore when people have inflammation where the Achilles tendon attaches. These are the two areas of the knee that get sore. And again, it's different from arthritis. You may still have knee pain, but this tends to not be associated with a big, warm, swollen knee. But sometimes there can be localized swelling right around where these two circles are. And then a lot of pinpoint tenderness when we press on those areas. So the top would be where the quadriceps attaches to the kneecap. And the bottom is where the infrapatellar tendon attaches to the bottom of the kneecap.
Did you want to ask how many people had children with enthesitis?
Oh, sure.
Okay. So we're at 57% voted, 70% voting, 76%, 80%. We're almost there. 85%, 87%. Okay. One more second. All right, we're closing the poll. Let me share the results with you. Go ahead, doctor.
Okay. So it looks like 40% of you know your child has enthesitis, 13% know that they don't, and it's interesting that a quarter of you aren't sure. And I'm actually not surprised by that because the enthesitis exam varies across the country and within physician to physician because there's really no standard enthesitis exam. So I'm not surprised at that. Another area that's often affected is the hip. And so, again, it can be mistaken for arthritis because it's really painful, but it's really just, it's just where the tendon attaches right at the greater trochanter. Okay, so we did a study a couple of years ago, and we looked at enthesitis using both physical exam as well as ultrasound, and we looked at 6 bilateral entheses that we thought were most likely to be involved in this disease. And by ultrasound, what we found were that the most commonly involved entheses in children were 1, the lateral part of the elbow, where the common extensor tendon attaches. The second one was the quadriceps attachment at the top of the kneecap, and the third most common place was the attachment of the Achilles tendon. And this fits clinically with what we hear from parents and kids in clinic too. We also found that by ultrasound, almost 2/3 of children had at least one site that was inflamed, and over 1/3 of children had 2 or more sites. And these are all children who were just pulled out of clinic and may not have been complaining. And so from this study, we concluded that ultrasound-confirmed enthesitis was common in these children. The other thing that was really interesting that we found in this study was that children with juvenile spondyloarthritis had more pain at every single entheses than comparator healthy controls. And the pain was increased whether or not they had ultrasound findings of inflammation. So there's something going on that these kids are just overall more tender than average children. It's unclear if physical exam or ultrasound is going to end up being more useful for monitoring disease activity in the future, and it's not standard for people to use ultrasound in practice to look at the entheses, but we're trying to do a lot of research in this area right now, so hopefully we'll have some more information for you in the near future.
Here's one more.
We have one. Yep.
Actually, we have one more after this. Do you want to talk about this poll or?
Sure. So one thing that I hear about is enthesitis can be really difficult to treat. And so I was interested in knowing how many of your children are having ongoing issues with discomfort from their enthesitis.
And we have 54% voting, 60, 72, 76, 78, So a few more seconds. All right, we're 80%. I'm going to go ahead and close this poll.
And so this doesn't surprise me at all either. So it sounds like about half of you have children where controlling the enthesitis is a real problem. It's good to know that 20% it's not an ongoing issue. But this can be really difficult to treat. Sometimes it responds to the same medicine as the arthritis, but oftentimes it doesn't. And so what do we do when people, their arthritis is well controlled, but their enthesitis is raging out of control? So stretching is something that is really important for these kids, and a lot of people think of it as not being a real intervention. It's incredibly helpful. Physical therapy, formal physical therapy, to show the children what exercises to do and how to stretch these tendons out is really very beneficial as well. For kids who have pain on the bottom of their feet, so at the plantar fascia, either under the attachment to their toes, so on the ball of their foot, or at the attachment under their heel, which is another popular area to be tender, shoe inserts or orthotics can be very, very helpful. The other thing that we can do is child-size heel cups. So if you use the adult-size heel cups and the child's not adult-size yet, it's going to actually cause more discomfort than to be helpful. But pediatric-size heel cups can take the pressure off of the heel and can also provide a lot of relief. Usually we say in terms of ice or heat, whatever feels better for the child. Both of them are helpful. If I have a child who comes in to me and just has enthesitis and has no arthritis, the first thing I'm going to try is a medication in the group of nonsteroidals, so the ibuprofen family. One of our favorite nonsteroidals, at least at my institution for treating enthesitis, is diclofenac, which is a twice-a-day medicine, also called Voltaren. Other ones that work really well are indomethacin, and piroxicam is a good one because it's a once-a-day medicine. But sometimes Motrin or ibuprofen works just fine as well. For those kids who don't respond to one or then a second nonsteroidal, medications we usually then give a try are sulfasalazine or methotrexate. And then intra-articular steroids, I'm sorry, that's an error that shouldn't be on here. It's not an enthesitis treatment. But sometimes if sulfasalazine or methotrexate don't work, our next step is then to use an anti-tumor necrosis factor agent such as Enbrel, Humira, or even Remicade. So I can't ask you for questions right now about enthesitis, but I will at the end. The next topic I want to talk to you briefly about is something else that makes juvenile spondyloarthritis extremely unique from the other kinds of chronic arthritis that we see in children, and that's because these children, like adults, are predisposed to getting arthritis of the lower back, which is called sacroiliitis. And I think we have our last poll question for you now.
Okay, launching it. And do you want to talk about this?
Sure. So I'm interested in knowing, before I talk about this, how many of you have children with sacroiliitis or arthritis of the lower back? Okay, so it looks like over 2/3 of you have a child with sacroiliitis or arthritis of the lower back, so this next section should be pretty pertinent to you. 21% of you don't have children with affected lower back. So what I'm showing you here, just so you know, is a picture of the lower back, and the part on the right is clearly abnormal, lighting up, and so that's a sacroiliac joint that's inflamed. And so sacroiliitis in children, again, 10 to 20% of adults with ankylosing spondylitis, which is progression of spondylitis to involvement of the spine and lower back, have onset during childhood. One thing that distinguishes sacroiliitis in children versus adults is that inflammatory back pain, or even any back pain, is much less common for children to complain of. It's almost never present when the disease is diagnosed or symptoms first start. But this doesn't mean that children aren't still at risk. And so we know from some longitudinal studies that sacroiliitis is going to occur in up to 40% of children within a few years of diagnosis. And so how do we monitor for this in clinic? So one way is we push on the sacroiliac joints to see if the kids are tender there. The other is we check the flexibility of their back, and so we usually make some marks right at the dimples of Venus, so that's that middle mark, and then we make a mark 10 centimeters above and 5 centimeters below. We ask the children to bend over, try to touch their toes, and we see how much change there's been, and usually we like to see that line is now above 20 centimeters in length. We did a colleague of mine did a retrospective study of about 143 children with juvenile spondyloarthritis who had had disease for about 3.5 years. And what he found is that in his cohort, about a third had sacroiliitis defined by clinical exam or imaging, and that many of these patients had no history of back pain or stiffness, and many had a normal back exam. They just happened to have sacroiliitis diagnosed incidentally because they were getting imaging of their hips or something like that. And in this study, risk factors for developing sacroiliitis were having hip arthritis or having those sausage fingers that we talked about that some of these kids can get. And the sausage fingers were actually protective. So in terms of sacroiliitis and these kids, we did a prospective study that's actually just being written up for publication right now. So it just closed last fall, and we enrolled 40 children with a diagnosis of juvenile spondyloarthritis. All had been diagnosed within the prior 6 months, and they were enrolled regardless of whether they had back symptoms or not. And then we also looked at 14 age and sex-matched healthy children. Everybody enrolled got an X-ray, they got an MRI of the pelvis, and they had a full exam. And what we found was that about 20% of our population had sacroiliitis, and that in many of these children they had absolutely no symptoms. And we found that 2/3 of our cases would have been missed if back pain or a history of back pain were used to screen for the disease. One thing you may hear from doctors is if they're worried about sacroiliitis, well, we should do an X-ray first. But oftentimes the X-ray is normal, but the MRI, which shows the active inflammation, is positive. So 1/3 of the cases in this study would have been missed if radiographs alone were used to screen. And in this study, again, it's a small study, but we found that children with high inflammatory markers and who were B27 positive were the most likely to have sacroiliitis. So in our last couple of minutes, I want to touch on treatment of children with SpA, and we're going to talk about treatment of kids with just peripheral arthritis and those kids with sacroiliitis. So treatment of peripheral arthritis, if there's no involvement of the spine or the lower back, is very similar to the way we treat the other categories of juvenile arthritis. And so our first-line therapy for these kids is methotrexate or sulfasalazine. These have established efficacy for peripheral arthritis. They've been around for decades, and we know that they work well. It's a first-line agent according to the American College of Rheumatology JIA treatment recommendations. Methotrexate has actually never been studied alone in children with spondyloarthritis, but it has been studied in children with juvenile arthritis, of which children with spondyloarthritis have contributed to the patient population. Sulfasalazine is the only one that's been studied in these children specifically, and that was studied in a 26-week randomized trial. And although they didn't meet their primary outcomes as pre-specified for the trial, they did find that active joint count, tender enthesitis count, and the children's pain improved significantly in both those children who got treatment versus who didn't, but that there was statistically more improvement in the kids who got treated. And for that reason, we do like to use sulfasalazine a lot. However, methotrexate and sulfasalazine, if we base this thought on the studies that have been done in adults, is not effective at all for the axial arthritis. So children who have arthritis of the lower spine may be put on methotrexate or sulfasalazine to help arthritis of the peripheral joints, but it's not expected to impact arthritis of the lower back. So sulfasalazine, just a little bit more about this, is an oral medication. It's twice a day. Usually children have response within 4 to 8 weeks, and the main risks of this medication are that 20% will develop intolerance or side effects, and they can include GI upset, rash, or dropping blood counts. Methotrexate comes as both an injection or an oral form. Physicians routinely prefer the injection because it's more efficacious and there's fewer side effects. But if there's an absolute contraindication or the family or child is absolutely against getting the injection, we can give it orally. Usually we give it with a multivitamin or folic acid. Again, response is not overnight. It takes 6 to 12 weeks. And risks with methotrexate are hepatotoxicity, which tends to be much rarer in children than adults, actually. Pulmonary toxicity is almost unheard of in children. The most common side effect that kids have are they can feel a little bit nauseous the 24 hours after administration. So when we talk about treatment of axial arthritis, it's sort of a whole different ballgame. And so the traditional medications like methotrexate and sulfasalazine, again, when we're talking about treatment for axial or sacroiliitis, arthritis of the spine or lower back, those traditional medications are not effective. So then we turn to a group of medications called biologics. And under the term biologics, the main ones that we use are tumor necrosis factor inhibitors, and those are the ones that you see commercials about all the time for adult RA and psoriatic arthritis. So they're Enbrel, Humira, Remicade. And so all of these medications, sister medications, are very effective for symptomatic treatment of the axial disease, but they may not be as effective as we want them to be for halting long-term structural damage. But there's a lot of studies going on to try and look at this longitudinally. Etanercept and adalimumab, or Enbrel and Humira, both come as subcutaneous injections. The person who comes up with the oral form of these will make millions and millions of dollars because children hate to be injected. And infliximab comes as an IV infusion that's given at 0 to 6 weeks and then every 4 weeks thereafter. So what about the kids who don't respond to TNFs? And there's a lot of them out there, and we're really trying hard to find medications to help these kids. So unfortunately, none of the medications that are on this slide are currently being studied in kids, but they're all being studied in adults, and that's just sort of the way things always go. Medications are always studied in adults first, and once we find things that are effective, then we get the trickle down, and then we start to examine them in kids. So rituximab, abatacept, and IL-6 inhibitors have been studied. Rituximab is modestly effective in patients who haven't seen an anti-TNF medicine before. So people who haven't been treated with Enbrel, Humira, Remicade may respond to rituximab. But the data is not supportive of using abatacept or IL-6 inhibitors for this condition. Rituximab we do use for other kinds of juvenile arthritis, so it's not a huge leap to say that it might work for this in children as well. Ustekinumab blocks something called IL-12/23 in the body, and this has been found to be beneficial for sacroiliitis in a small group of adults with ankylosing spondylitis. Again, this hasn't been studied in children yet. Secukinumab is another medication that's an anti-IL-17A blocker, and there's been one small trial in ankylosing spondylitis that's showing some favorable results. And then apremilast, which is a PDE4 inhibitor, is also being investigated. So the point of this slide is to tell you that, number one, we make medication names that are tongue twisters, and you're not expected to remember any of them. But the other thing is really just to give you hope that there's a lot of new medications coming out on the market right now, many of which we think may be really good options for treatment of sacroiliitis and lower back disease. They may be beneficial in terms of symptoms. They may work better in terms of preventing long-term structural damage. And we really want to find them for those kids who are on anti-TNF therapy who aren't responding. And so have hope, but it's going to take us a little while to get there. And so one other question that came in that I thought would be relevant to talk about when we talk about treatment of disease is I always get asked in clinic after we talk about medications, well, doctor, is there anything else that you might recommend that we do, special diet, things to avoid? There's lots of books out there. I just want something else to be able to do to help my child. And you know, my response usually is there aren't a whole lot of things that have been shown to be truly efficacious in terms of clinical trials, things that, you know, the way we determine what medications to use or not use in these kids. But one thing that has been shown to be helpful is fish oil or omega-3 fatty acids. So for the families that are really looking to do something, if their child likes fish, salmon is a great choice, and that may provide some relief. But the caution I always give is that this may be beneficial, but it's never going to take the place of the medications. So I use dietary things are adjunctive, but keep your eye on the prize in terms of making sure systemic medications are adhered to. So in summary, and then we're going to open this up for questions, juvenile spondyloarthritis, of which enthesitis-related arthritis, psoriatic arthritis, and undifferentiated JIA all fall under that umbrella term, accounts for about 20% of chronic arthritis that we see in kids. HLA-B27 is the big player in terms of heritability. Microbiome, or bacteria that live in the gut, and its role in the pathogenesis of this disease is being actively researched, and I'm hopeful that it's going to give us some answers. Enthesitis is really common and often problematic, particularly with the pain. Sacroiliitis is really common in diagnosis. Sometimes it's symptomatic, but oftentimes it's not. Methotrexate and sulfasalazine are great choices for peripheral disease, and the anti-tumor necrosis factors are typically very effective symptomatically for children with lower arthritis, lower back arthritis. But unfortunately, they're not the cure-all because they're not terribly effective at halting structural progression. And so before we end, there's just a lot of people that I have to thank who've contributed to my own research in this area, and then funding, and then again the SAA for their support with the Bruckle Young Researcher Award. Now I think we're going to open it for questions from you, if there's things that you want to know about that I haven't addressed.
Yeah, okay. Well, thank you. That's been so informative. And there are a lot of questions. Let me reintroduce Aline. She's going to voice the questions that she's been receiving online. Aline, by the way, has been with the SAA staff for 7 years. She's the editor of Spondylitis Plus magazine. She's our resident social media and programming guru. She's been monitoring the questions, and she'll ask them out loud for everybody. Aline, can you take over?
Thank you, Rich. Yes. Hello, everyone. I'll just jump right in. Can anyone hear? Dr. Weiss, can you hear me okay?
Yep, I can.
Okay, great. So we're going to start with Vanessa's question, who wants to know if there's a particular range of ages in which juvenile SpA symptoms are most likely to occur.
Yeah, that's a terrific question, and the answer is yes. So it's highly unusual for the symptoms to start in children under 6. And once they reach age 6, it's still pretty not that frequent. I would say the average age of onset of symptoms is right around that 10 to 12, 13-year-old age. So right, the pre-adolescent age is the most common age for symptoms to start. And then it just goes up from there.
Thank you, Dr. Weiss. Next question from Kristen. Can you talk about incidence of anxiety, depression, and fibromyalgia in kids with chronic pain? And does a pediatric rheumatologist screen for this on a routine basis?
So I can't talk about specific proportions of children with juvenile spondyloarthritis that have anxiety, depression, and fibromyalgia because I don't think anybody's ever looked at it. I can tell you that we do see a lot of pain in these children, but I see a lot of pain that's not fibromyalgia, but I also see some that is characteristic of fibromyalgia. Pediatric rheumatologists are very in tuned, more so to fibromyalgia than they are to anxiety and depression because we treat primary fibromyalgia as well. And when we see a child who comes in with pain that's out of proportion to what we're used to seeing with spondyloarthritis, we usually try to treat the underlying disease first, and then we also incorporate treatments for fibromyalgia, which depending on where you go can be very different. At CHOP, our treatment of fibromyalgia is just really intense exercise and physical activity for deconditioning.
Thank you very much. Next question. Jana says, my son is 14, was diagnosed at 12. His symptoms began when he was 9. His treatments have turned him around 180 degrees, and he is now doing well. He's on a TNF medication. So question is, what is the predicted outlook for young patients like him who are treated early? Everything I find in researching is very discouraging.
So that's a great question, and I'm glad that your son is doing better. That's primary. The follow-up to that is a lot of the long-term studies, and there aren't that many that are out there, but those that are out there, I agree with you, they are discouraging. But the one thing I would say to you is that many of the long-term studies that are out there are on children who weren't treated early or who were treated before the anti-TNFs started to be used in children. So I suspect that over the next couple of years, decade, we'll start to have more longitudinal studies, and the outcomes in these children are going to be better. And one of the other reasons that I say that is that, one area that I'm particularly interested in is trying to look for the arthritis of the lower back. So that's the big one that really impacts the long-term outcome of these kids. I'm interested in looking for it before the kids present with symptoms. So I'm starting to look for it at diagnosis and trying to see if that's useful for us in terms of a practice change. And so if we can figure out which kids are going to develop the axial arthritis, we find it at the earliest possible moment and get them treated, I can't help but hope that we're going to impact the long-term outcomes for these kids. The other reason I have hope that these kids are going to do better in the long run is that there's so many new drugs being developed right now, which may end up working even better than the anti-TNFs. And so, I think outcomes have improved a lot in patients who are treated with anti-TNFs versus those who weren't. But I think that we have a lot of potential to do even better with some of these newer drugs.
Thank you very much. Could you discuss if a person should be concerned about a teenage boy with juvenile spondylitis playing football? The constant hitting, could that cause issues?
Sure, and so that's a question I get from a lot of my patients too. And so the answer I usually give is no, and that's several-fold. So if your child's doing well and the arthritis is controlled, then they should be able to participate in sports just like other kids. And getting knocked around with some of the higher impact sports is not going to put them at risk if their arthritis is already in remission. And I think it's really important for these kids that are on medications to feel like normal kids. And so if playing sports is something that really they feel passionate about and makes them feel normal, I think it's important to encourage them to do it. As of now, there's no data to show that repetitive impact on the joints puts them at risk for damage in the long term.
Thank you very much. Next question, does enthesitis show up in SED rates for inflammation?
So SED rates are one of those inflammatory markers that we talk about. They're really non-specific, and so they can be elevated if your child has a cold or has a GI bug or anything. I am not familiar with enthesitis alone causing a SED rate elevation, but I haven't really looked at it. I don't know anybody who has.
Thank you. Could you discuss some of the issues and challenges associated in switching from pediatric to adult rheumatology?
Yeah, so that's a really great question too. What we tend to find, at least in our clinic, is that the children and parents don't want to go on to adult care. I think people get attached to providers when they get their diagnosis and they get comfortable. I think a challenge is, number one, encouraging people that the adult providers are fantastic too. They actually probably see more of this disease than the pediatric rheumatologists do. In terms of the kids, particularly if they were diagnosed early, they're probably used to their parents reminding them to take their medicines, reminding them to get their refills, or their parents are calling for refills, and they're probably giving the kids the medication. So as we get these kids ready to transition to adults, there's a couple things we need to focus on. One, they need to learn what medications they're on, what the names of them are, and why they're on them. Two, we need to start encouraging them to give themselves their own medication, particularly for the kids who are going to college. It'd be nice for them to be able to give themselves their own injections. And they need to start remembering to take the medications themselves, because you're not going to be at their side all the time. And so I think learning to let go and give your child independence is really a struggle. And then a lot of these kids learning to take on the burden of remembering that and taking ownership of their own disease is a challenge. And then the other big transition is the kids will start coming to the doctor without you by their side, which I think can be difficult because then you don't have a direct avenue to asking questions, which is somewhat comforting. But have confidence your kids will be able to handle this. If you start early and start helping them with transitioning to some of these duties early on.
Thank you. And kind of related, what do you call J-SPA when you become an adult?
So J-SPA just becomes SPA, remove the J. And so what they'll then refer to it as when you see people in adult clinics, they'll say this person has spondylitis or ankylosing spondylitis that started when they were a child.
Thank you. What do you do when a child runs out of options? They've been on Enbrel, Humira, Makeda, and Simponi. What to try next?
So there is a challenge. I think that's a great question, and I don't have a great answer for you right now because a lot of these drugs that are out in the adult aren't being studied in children. So in the adult realm, when you've run out of all of the options that are available on the market, usually that's when it's a good time to think about the randomized controlled trials. It may be that some of these trials start up in kids in the next few years, but right now they're not ongoing.
Got it. Have you heard of Adderall being used to reduce inflammation?
I have not.
Okay. My son was diagnosed with AS at 19, started Humira within 2 months. It's working well. Can he go off Humira to try less potent medications and still have the option of going back on Humira without side effects or allergic reactions?
So that's a great question, and I will tell you, number one, it's great that he's feeling much better after starting because I'm sure that's huge for him. There are options. Humira doesn't have to be lifelong. There's always the option of coming off medication and restarting if symptoms come back. I will tell you that for adult spinal arthritis, patients with sacroiliitis are not always treated with anti-TNF medications. So there's many patients out there who are well controlled symptomatically on just non-steroidals. And not everybody with sacroiliitis is going to progress. So some people have inflammation at those sacroiliac joints in the lower back that don't go on to have structural damage. We don't know which ones are going to or not. We don't have a great predictive model right now, but not everybody will progress. So some people do fine on being on something like NSAIDs. In my own clinical experience, in many of the kids who do stop the medication, the pain comes back, and the children then do want to go back onto the medication, but that's not to say that happens in everybody.
Thank you. Do you have any advice on how students can advocate for themselves in the school setting? My son is often met with skepticism because he looks fine. In order to get some understanding, he has to share more information than he feels comfortable with.
So that's tough. So there are resources available for kids to help advocate for themselves. I think protecting their own personal medical history is something that's something they're definitely entitled to. But organizations like SAA or Arthritis Foundation, any of those places may have other individuals or other teens that your son or daughter would be able to talk to get some ideas, because I'm sure that other children and teenagers have faced the same thing in the past. And I do believe there is a teen group that SAA has, right?
Yes, I was going to just jump in and say this question is from Eileen, to say that on our website, SWIFT, that's teens.spondylitis.org, we have a lot of resources, stories from teens talking about just that exact thing, and also how parents can request, I think they're called 501 plans, which would basically have teachers know that this child might need additional time to go from class to class and whatever the issues may be, so they are aware and they are handling it well. So if you'd like to email us at info@spondylitis.org, I will get back to you with more resources on that as well. And I think we are at 11:59. So Rich, what would you like to do?
Yeah, here's what I propose. And I haven't talked to the doctor yet about this, but let me do a short wrap up, thanking people, and then if the doctor can stay on a little bit longer, We'll come back to questions and answers, but I think you're right, to be sensitive that it's been an hour, so we should probably, let me do the wrap-up. So here's a plan. I'll do the wrap-up. If the doctor can stay online for another 10 minutes or so to answer some of these additional questions, that's great. And I suppose the questions, we can log the questions after the whole, if we don't get to them all, and since we have people's emails, we can respond that way as well.
Absolutely.
Okay. So, well, let me say how grateful I am to Dr. Weiss for generously spending her expertise and her weekend with us. And I want to thank, of course, all the attendees that are on the webinar. I wish no child was in pain or have spondylitis, and we're working every day here for a quest for a cure. And of course, thank you to Aline and the rest of SA staff who are here on the weekend working in the office. I'm also deeply grateful to the Reagan Family Foundation for funding this webinar series. The SA does not receive any government funding. It continues to be up to the people living with spondylitis and their loved ones to support the work of SAA. And if there's one thing I'd like to suggest everyone online do, is that they read a monthly email called the eSUN that we send out. Any breakthroughs in spondylitis, any new medications, anything new with Spondylitis World is going to be announced there. It's very concise, it's very informative. There's only 3 to 5 items there. Also lists local support groups. So again, I want to thank everyone for their attending and wishing them a wonderful rest of the weekend, and a reminder to please complete the short survey you'll receive as soon as you exit. So now I'm going to go back to, so that was my farewell. You can leave if you'd like, or if you'd like to stay on for a few more questions, I'm going to turn it back over to Aline and Dr. Weiss. Aline, are you with me?
Okay. Thank you. Yes. So the next question is related to triggers and causes of juvenile and adult spondyloarthritis. In your experience, do you suspect, or have you found in research that having a stressful childhood or a difficult birth or any kind of trauma perhaps in childhood increase the likelihood of developing spondyloarthritis?
That's a great question. I haven't come across any literature that would say that injuries are more common in kids that develop spondyloarthritis. The one thing that is, it's not trauma related, but that it has been in some very, very early studies showing that children who receive antibiotics more often in childhood may be predisposed to developing juvenile arthritis, again, of which spondyloarthritis is one of them. And so, again, that gets back to the microbiome and bacteria that live in your gut and how antibiotics disrupt that, and that may, we may find that that's one of the causative reasons for developing autoimmune disease, including spondyloarthritis.
Thank you. Can someone with spondyloarthritis have periods of time without pain, basically go in remission?
Sure. You know, and I don't know if you're talking about remission on medication or remission off medication, but as, you know, if we talk about juvenile arthritis in general, we have lots of kids that are completely pain-free and feel exactly like every other kid when they're on medications. And in some of these kids, after a period of a year or two, we're able to peel the medicines off, and they can stay in long-term remission for a while. Sometimes that's 2 months, sometimes that's 2 years, and sometimes the disease doesn't come back. And so, sure, I think pain-free remission is definitely something that, that you can look forward to. The long-term studies, at least in children that have included ERA, so one of the subsets of spondyloarthritis, show that the vast majority of kids do not have prolonged remission before they eventually have to go on medication. But again, short periods of remission are not out of the question.
Thank you. Are there other medical professionals besides rheumatologists that people with spondyloarthritis can see or perhaps should consider adding on to their medical team?
So that's a great question too. So when we think about pediatric rheumatology, depending on where you are in the country, there may not even be a pediatric rheumatologist to care for you, which is tough. But there's still states out there where there aren't any. But if you are fortunate enough to have a pediatric rheumatologist and want more comprehensive care, the kind of team that we often encourage people to have are again include people, physical therapists. or occupational therapists if that's something that helps the kids feel better. If pain is above and beyond what's expected for the primary condition, and we think that amplified pain or fibromyalgia is complicating things, then talking to a therapist can actually, and for stress reduction, that can also be very helpful.
Thank you. Do you test children for vitamin D levels? The question comes because enthesitis being a common symptom in adults, they find that many test below, and they're wondering if this is also the case in children.
So that's a great question too. Routinely, we do not check for vitamin D in children at this time. There are a few autoimmune conditions that we do routinely check for vitamin D in. This just doesn't happen to be one of them. I'm not aware of any studies of vitamin D in juvenile spondyloarthritis personally. So no, right now we don't check.
Thank you. Can Severe's be confused with enthesitis?
So Severe's disease can definitely, can definitely be confused with enthesitis. So there are, so Severe's versus enthesitis, it's hard to tell the difference. So Severe's is something that orthopedists usually diagnose. And Severe's is different from enthesitis in that you actually get micro fractures or tears of the ligaments or tendons that are attaching, whereas with enthesitis you don't usually get tears, but you get inflammation. And the other, so Sinning-Larsen-Johansson is basically Severe's of the lower kneecap. That orthopedists diagnose, and so that again is micro tears, and that's in contrast to enthesitis of the lower kneecap that is just inflammation of the tendon insertions. There's not a great way to distinguish between them. Sometimes if you do imaging of the area, you can see some differences in the imaging that'll show the micro tears, but usually we don't do that.
Thank you. There has been lots of research recently on gut bacteria impacting spondyloarthritis and Crohn's and such. Are there simple ways to restore the microbiome or the gut bacteria other than probiotics?
And that's a great question, and probiotics are the only thing that I know of right now. There's some studies going on in inflammatory bowel disease that have looked at I want to say they're almost like a transfer of different, a whole different, I think they're called stool transplants.
Oh, fecal implants.
Fecal implants, that they're starting to study in inflammatory bowel disease to actually do something other than just probiotics. That, to the best of my knowledge, has not been tried or been studied at all in spondyloarthritis, but I imagine that it's probably not too far down the line.
Okay, and somewhat related, is the outlook for kids with J-SpA and inflammatory bowel disease that can run independent of GF flares, is that better or worse than typical J-SpA, which I'm assuming is without inflammatory bowel disease?
Yeah, so that's a great question too, and I don't know that anybody's looked at the long-term outcomes in kids with juvenile spondyloarthritis with and without the associated bowel disease. The kids with bowel disease are at risk of for sacroiliitis just as much as the other kids, and so I think the sacroiliitis risk factor is really the main thing that's going to impact their long-term progress. But in my clinic, at least, the kids who've had associated inflammatory bowel disease have responded just as well in terms of their joints to the anti-TNF medications or methotrexate as the kids who don't have concomitant bowel disease.
Thank you. Do you see many teens having the issues with inability to get a restful night's sleep? And if so, or when you do, what are some solutions that you suggest?
So I see lots of teens with and without spondyloarthritis that aren't able to get a restful night's sleep. It's incredibly common, and I think that is just part and parcel of being a teenager. And so usually the first thing we talk about is sleep hygiene, keeping a steady bedtime, trying to get up at the same time every day, not napping in the afternoon, no matter how tired you are. And then the other thing I recommend for these kids is to increase physical activity so that they're weary at night and able to fall asleep a little bit better. I don't prescribe medications for these kids to go to sleep.
Thank you. Do you recommend going to see a GI due to the prevalence of gut issues in people with spondyloarthritis? So I'm assuming the question is, even if the person isn't having GI issues, do you recommend checking for that potentially?
No, I don't. I think that's a great question. And the reason I don't is that I'm always looking for it. And so on the routine screening labs that I do on my children with spondyloarthritis, there are some things in there that are that we look for to be off. And if they are, or if the child's not gaining weight well, or if they're not growing well, those will all be reasons that we would send them to the GI doctor. Having them going and get screened by the GI doctor if they're not having any symptoms, very few gastroenterologists would want to take a look with a enteroscope or a colonoscopy to see if there's inflammation or not. Nobody's going to look invasively if there's no symptoms.
Thank you. I think this is a follow-up question from your presentation. The question is, what does sausage fingers being protective in quotation marks?
Oh, okay, sorry. So maybe I didn't state that clearly. So in that study by Dr. Stoll from Alabama, in his cohort, he found that those children who had fingers that were basically swollen from the knuckle all the way to the fingertip, those are what we call sausage digits. Kids who had sausage digits were much less likely than other kids with spondyloarthritis to get sacroiliitis.
Okay, thank you. Maybe just a couple of more questions. I have a child with severe spondyloarthritis and 2 who are now showing symptoms. Could there be something in our environment that is causing spondyloarthritis to be active or triggering it?
So I guess the answer is it's always possible. I would suspect that if it's that prevalent in your family, that there's probably some genetic component that's causing a lot of the issues too, and that may be an opportunity to have the genes tested to try and find some other causative risk factor other than B27.
And if anti-TNF doesn't halt the disease, what will halt or slow that, or what is being looked at as potential for slowing or halting progression?
So a lot of those cytokine blockade treatments that are on the IL-17/23 pathway that were on that final slide of the treatments that I had mentioned, those are all the ones that are being actively investigated. And so the first thing they need to do is to investigate whether those medications help symptomatically. And then they need to study what the impacts are over the short term, and then once they find that they're effective over the short term, then they do the long-term studies. And to be able to declare a medication to be helpful in the long term in terms of stopping structural progression, we need studies that extend out past 5 or 6 years. So it takes a long time to be able to show that.
Thank you very much. I suppose one last question, and let's make that what percentage of teenagers, in your experience, with sacroiliitis do not respond to anti-TNFs?
So that's a great question. The minority for sure. But I probably would throw out a number just off the top of my head, 10% maybe don't respond to anti-TNFs. And of those who don't respond to the first TNFs, a lot of them respond by switching TNF. So if they're on something like Enbrel, sometimes switching them to a second anti-TNF like Humira or Remicade is helpful. And so that's the first thing to try. And then the second thing are, to see if your rheumatologist can get some of these other medications that are approved in adults, approved for your child, though that's very challenging with the insurance companies.
Okay, thank you very much. We went through most of the questions that were asked. There are some that we didn't get to, and so those we will respond to in some form in email. Either we will or we'll ask Dr. Weiss to answer, and we will pass on to you. I'm going to hand it off to Rich, but I just wanted to say I want to encourage everyone listening to please go to teens.spondylitis.org. That is obviously our teen website. We do have a lot of information on there, a lot of stories from teens, and there's a link there you can find that will go to a Facebook group that is for teens with spondylitis, young adults with spondylitis, as well as parents of teens. And it's a great way to connect with others, share stories, and find out what is being helpful for others. Thank you so much for me, Dr. Weiss.
Oh, you're welcome. This was fun.
Okay, well, we still have about 2/3 of the people, so let me just do a final send-off. Thank you. I don't want.
I just want to say thank you to all of the parents, because parents who are interested and ask questions on behalf of their kids, and they're some of the best gifts that the kids that we see in clinic can have. So you guys are all to be commended for being interested enough to give up a Saturday for a few hours to listen.
Well, let's leave on that note then. That was perfect. All right. So thank you everyone for attending, and we'll see you next time.